Good afternoon, and welcome to the fifth webinar of 2021 in the ACCP Immunology and Transplantation PRN Webinar Series. My name is Tara Veazey, a cardiac transplant pharmacist at Allegheny General Hospital in Pittsburgh, and it is my pleasure to moderate today. Today's webinar is titled the ISHLT Recap Webinar, and we are honored to have Dr. Shelley Goyle and Morgan Mabey-Eiting present for us today. Dr. Shelley Goyle is currently a PGY1 pharmacy resident at Loyola University Medical Center in Maywood, Illinois, and completed her doctoral education at University of Texas at Austin College of Pharmacy. Shelley will be staying on at Loyola as the PGY2 solid organ transplant resident next year. Dr. Morgan Mabey-Eiting is currently in the process of completing her PGY2 pharmacy residency in solid organ transplant at Massachusetts General Hospital in Boston. She completed her pharmacy school education at Virginia Commonwealth University School of Pharmacy and her initial pharmacy PGY1 training at Boston Medical Center. In a moment, I will turn it over to Dr. Goyle to begin the presentation, but first, here are a few quick notes. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will take questions at the completion of the presentation. There will be an evaluation for this webinar available at its conclusion. We encourage you to complete this to let us know how we did and how we can improve our webinars going forward. The slides from today's presentation will be posted on the ACCP website in the section titled Webinar Slides after the presentation. If you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware through the chat functionality. There's also a live chat in the upper right-hand corner of your screen where you can get live technical support from any meeting. Now, without further ado, I will turn it over to Dr. Goyle.
Thank you, Tara. Thanks for that welcome. And like Tara mentioned, my name is Shelley Goyle, and I'm a current PGY1 pharmacy resident, and I'll be presenting on two topics that were discussed during the ISHLT 2021 meeting, including left ventricular assist devices and heart transplant. So here is just a slide summary of all the abbreviations used throughout the presentation for your reference. And I'll start with left ventricular assist devices, or LVAD updates. The objectives are to summarize updates in HeartMate 3 management regarding antiplatelet therapy and to evaluate goal-directed medical therapy optimization strategies in LVAD patients. So I want to start off by discussing the antiplatelets in HeartMate 3 and what we already know. So the antiplatelet therapy for this population has been evolving over the last decade for its role in primary prevention of thromboembolic events in addition to warfarin. And this year, there was a particular focus on HeartMate 3. The guidelines recommend that low-dose aspirin 81 to 100 milligrams daily is initiated for HeartMate 3 recipients. And although recommendations are weak, there are no prospective randomized studies to show that warfarin plus aspirin, even at low doses, is beneficial and safe in these patients. It's something that we do, but it's poorly rationalized entirely. So the existing evidence includes a study by Lim and colleagues in 2019 that was a retrospective chart review of HeartMate 3 implants, and it looked at bleeding and thromboembolic events. They initiated and continued warfarin in addition to low-dose aspirin for 3 months or until the first bleeding event. After this event, they discontinued aspirin and continued monotherapy with warfarin. They found that there were 8 bleeds in the combination group and 1 bleed in the monotherapy group. There were no thromboembolic events in any patients, and the overall 1-year survival was 91%. The 12-month event-free survival was significantly higher in the warfarin monotherapy at 97% versus 65% for the combination, showing a favorable profile of warfarin monotherapy. Ultimately, Lim and colleagues concluded that discontinuation of aspirin post-implant, either in response to a bleeding event or at 3 months post-implant to reduce bleeds, is a reasonable approach to antithrombotic management in HeartMate 3. And so then this year, the new evidence included a 2-year follow-up by Lim and colleagues of the same study where they published the 2-year results. So the warfarin monotherapy cohort had 53 patients, and these were taken off of aspirin at about 4 months on average and remained on warfarin monotherapy for a median duration of 459 days. Bleeding events remained higher in the combination group, with 20 episodes that occurred in 18 patients in the warfarin and aspirin group, versus the 6 episodes in 3 patients in the monotherapy group. Out of the 6 bleeds in the warfarin-only group, all of them were GI bleeds. The bleeding events did not require blood transfusion, but no fatal bleeds. The bleeding events did require blood transfusion, but no fatal bleeds were noted in either group, in addition to no thromboembolic events at the 2-year follow-up mark. The overall survival was 82%. So in conclusion, the parent and follow-up study looked at the effects of early discontinuation of aspirin, where the authors concluded that monotherapy is not associated with increased thromboembolic events in patients that are implanted with a HeartMate 3. So next, there was a study by Hollis and colleagues that presented their research out of UNC in Chapel Hill, North Carolina, and it was titled Safety and Efficacy of Warfarin Alone for the Prevention of Hemocompatibility-Related Adverse Events in Patients with a HeartMate 3 LVAD. They compared bleeding and thrombotic events in 28 patients on warfarin monotherapy versus 53 in the combination group. The mean follow-up was 285 days total, and baseline demographics were well matched, but the discontinuation of aspirin was actually not influenced by other comorbid conditions or indications, such as coronary artery disease, peripheral artery disease, or CAV. In other words, if patients had other indications to be on aspirin, this was not accounted for. The primary outcome event occurred in 23 of 53 patients in the aspirin group and in 3 of 28 patients in the no aspirin group. The curve shows this primary outcome and essentially boils down to this, that not being on aspirin increases your likelihood of not having a hemocompatibility-related adverse event, or put in other words, being on aspirin increases your likelihood of experiencing one by a factor of 3. The primary composite outcome was primarily driven by bleeding events. With that, this is the first comparison of the effects of complete omission of aspirin and omission of risk stratification, regardless of baseline indications for antiplatelet therapy. The authors concluded that complete omission of aspirin, independent of other compelling indications, was associated with less bleeding events without increasing thrombotic events. So next, I want to talk about what is on the horizon in terms of antiplatelet therapy. The evolution of this and withdrawing aspirin entirely has transitioned over the last decade, and there is argument against maintaining aspirin in these patients, which partially stems from a lack of absolute reason to use it, and perhaps it's a rule of habit, and its role in practice isn't as evidence-based as a theoretical mechanism of action. In addition, there has been emerging data showing thrombotic complications are not increased and that bleeding rates are same or better without aspirin. As such, we eagerly await the results of this active study that is listed on the left of this slide, and it's titled ARES for short, but it stands for Antiplatelet Removal and Hemocompatibility Events with the HeartMate 3 Pump IDE study. It is going to be the first international, first ever prospective, well-powered randomized control trial in this field. It'll compare the usefulness of aspirin in HeartMate 3 patients by comparing 1-year survival. Authors mentioned that it should be published around 2022. However, this is just something that is going on actively as of this moment, so just be on the lookout for this over the next year. So next, I want to talk about Gdmt and Lvad and the new evidence that was presented. The 2 studies that are listed on the left of this table by DeBruy and colleagues and Martis and colleagues essentially used the same study, parent study, to look at different outcomes. So for the DeBruy study, they looked at the impact of provider education and a protocol that was primarily pharmacy-driven on the prescribing of SGLT2 inhibitors in LVAD patients. And the study by Martis and colleagues looked at the impact of the same protocol on the prescribing of other GDMT therapies. It was a retrospective cross-sectional cohort study And it was a pre-protocol versus post-protocol evaluation with 116 and 156 patients respectively. What they found was that the prescribing of SGLT2 inhibitors as well as other GDMTs, such as ACE inhibitors, calcium beta blockers, ARNIs, ARBs, and GLP-1 agonists were all significantly increased, and the prescribing of non-GDMT therapies was significantly decreased. This last study by Straw and colleagues looked at the effectiveness of ARNIs in the improvement of MAP. Essentially, they wanted to see if ARNIs were effective in blood pressure reduction and they were tolerable. It was a longitudinal retrospective cohort study. Patients were prescribed sacubitril valsartan, or SV for short, in 46 patients that were all LVAD patients. As you can see, they measured the MAPs at various time points. They had baseline, 1 month, 3 months, 6 months, and the last follow-up. And they found that each of those was statistically significant in terms of MAP reduction of 12.2 millimeters per mercury on average. They followed these patients for 224 days, and the average dose was 24 by 26 milligrams. So in summary, what we found was the antiplatelet therapy in HeartMate 3 patients. The complete omission of aspirin from the antithrombotic regimen of patients is associated with less bleeding events without increasing thrombotic events. The upcoming ARI study will look at the usefulness of aspirin in this population, and it is much awaited. In terms of goal-directed medical therapy, the SGLT2 prescribing initiative found that significant improvements in optimization of goal-directed medical therapy was seen in terms of all of those agents, and that fewer patients received non-GDMT. Sacubitril valsartan significantly and safely reduced blood pressure in terms of MAPs in LVAD patients. So next, I want to discuss some of the updates that were discussed for heart transplant. The objectives are that we will evaluate novel induction and maintenance immunosuppression strategies, summarize highlights related to cardiac allograft vasculopathy, or CAV for short, and we'll review the ISHLT Hepatitis C virus consensus conference recommendations. So to begin, this is a study by Lee and colleagues from University of Washington Medicine that was a retrospective study looking at the effectiveness and safety of rabbit antithymocyte globulin, or RATG, at a total dose of 4.5 versus less than 4.5 milligram per kilogram total. In other words, they looked at full versus partial RATG doses based on their institution's induction protocol. The primary outcome was the incidence of acute cellular rejection based on the ISHLT 1990 criteria at 2 years. They included a total of 201 patients, 61 in the partial and 140 in the full groups respectively. Baseline characteristics, including gender, LVAD support before transplant, and baseline lymphocyte count were similar between groups. Looking at the table on the left, we can see that there was no difference in any grade of acute cellular rejection, as well as grade 2 or more at 2 years. In terms of the cumulative incidence of ACR grade 2 or greater, the authors mentioned that there was a trend towards increased incidence in the partial versus full induction group, with 18 versus 11.4% respectively. The number of patients with at least one infection within 3 months of transplant was similar between groups. All other secondary outcomes were also similar between groups. So overall, the authors concluded that doses of RATG do not appear to affect the overall incidence of ACR. However, total RATG doses less than 4.5 milligram per kilogram may not be adequate to prevent early severe ACR post-heart transplant. So this study by Chang and colleagues from Cedars-Sinai was a retrospective chart review that looked at real-world outcomes in heart transplant recipients who were switched from tacrolimus to cyclosporin in addition to mycophenolate between 2010 and 2017. They identified 58 recipients who were switched to cyclosporin, and this was mostly due to neurologic side effects from tacrolimus, primarily seizures and altered mental status. For comparison, the tacrolimus group was matched based on age, sex, baseline renal function, and time from transplant. The average time of this switch occurred at about 6.6 months post-transplant. Baseline demographics were well matched between groups in terms of donor and recipient age, BMI, history of diabetes, treated hypertension, prior blood transfusions, CMV mismatch, and being listed as status 1 at transplant. Of note, over a third of patients in both groups were sensitized with a panel reactive antibody greater than 10% pre-transplant, with that percentage being 34.5% or 20 patients in both groups. All study endpoints are listed in the table for your reference. They found that cyclosporin group had significantly lower subsequent 3-year survival and significantly higher serum creatinine and GFR at 1 year compared to TAC. In terms of rejection outcomes, there was no difference. The authors concluded that there are indications that a switch to cyclosporin from tacrolimus may be inferior in heart transplant recipients. However, what I found of particular interest was the finding that cyclosporin group had significantly worse renal function at 1 year compared to tacrolimus, since both agents in the CNI class are generally comparable in terms of nephrotoxicity. Additionally, these patients had a lower 3-year survival, so it would be interesting to see the cause of death between groups. During the presentation, the authors did mention possibly looking more closely at cause of death, and especially those related to infections, since those with severe CKD or end-stage renal disease tend to have more hospital readmissions and infectious processes at play. So next is a study that I completed with some of my colleagues here at Loyola University Medical Center titled Association of Infection Rate in Heart Transplant Recipients with Combined Tacrolimus and Sirolimus at High versus Low Concentration. We completed a single center retrospective chart review of patients who were started on sirolimus post-transplant in addition to tacrolimus for a total of at least 1 year in duration. And the addition of sirolimus should have been at the time point of 6 months post-transplant or later. We assessed the impact of the concentration of tacrolimus plus sirolimus concentration on infection rate. The two groups were divided into high, which was greater than 15 nanograms per milliliter, versus low, which was less than 15 nanograms per milliliter. Per our institution's policy, we target sirolimus at 5 to 7 and tacrolimus at 5 to 8 nanograms per milliliter at 6 months post-transplant and beyond. So if a patient was on therapy for a total of 3 years, we looked at year 1 and year 2 and year 3, and if they went from one group and switched over to another, they were discontinued from the treatment arm for the year that they stopped. So for this patient over here in the example, this patient was included for years 1 and 2 and not for year 3. So what we found was that the infection rate per year in the high tacrolimus-sirolimus group was significantly higher than that of low tacrolimus-sirolimus group. Additionally, there was no difference in rejection outcomes between groups. However, the reason to discontinue sirolimus did find a statistically significant difference in terms of the patients who did not have any discontinuation. So those in the low group did not discontinue combination therapy, which at the end of the day yields that higher combined tacrolimus and sirolimus concentrations was associated with increased infections per year, and it resulted in increased incidence of discontinuation. So patients in the low group may tolerate the combination therapy more so than those in the high group. So next I want to talk about the CAV management that was discussed in ISHLT. So CAV, like we mentioned, was cardiac allograft vasculopathy, and this presentation by Dr. Goldriak and colleagues was presenting the different treatment options that we currently have for CAV and looked at the established benefit versus likely versus potential and no benefit. So the first thing I'm going to talk about are Mtor inhibitors. These are a class of immunosuppressants that have deleterious effects for the development of CAV, and they've been recognized to have protective effects and noted to delay progression of CAV, with early start being superior to late start. So the data on the top that is published here, the graphic on the top, is from that of Wynn and colleagues. It was published in 2021. And essentially, they looked at the FDA adverse events that were reported in those that received tacrolimus versus Mtor inhibitors. And they had a total of 7,500 patients in the tacrolimus group and 1,300 patients in the Mtor group. What they found was that there was a higher odds ratio for having a cardiovascular event with Mtor inhibitors versus tacrolimus, and the cardiovascular events that were notable were heart failure, chest pain, and edema. The graphic on the bottom displays the benefits and risks of PSIs, or proliferation signal inhibitors, such as Mtor inhibitors, that are in addition to the cardiovascular effects. So there is controversy around their safety, but it is notable that most prospective studies look at CAV benefit in terms of a CAV surrogate endpoint. So at the end of the day, it really is a risk versus benefit situation for individual patients and should be evaluated based on their comorbid conditions and prognosis. Next, they briefly discussed the role of induction therapy in CAV. For the thymoglobulin, they looked at the potential benefit of induction with this therapy and found that it may have a protective effect as induction, as the odds ratio for having a maximal percent of stenosis greater than or equal to 30% was statistically significant. In terms of rituximab therapy that was used for the treatment of rejection, they found that there was, although a statistically significant difference in the change in percent atheroma volume, this was not clinically significant, and it was similar to the placebo. However, I think it's important to know that the rituximab's benefit for CAV has actually not been studied in an apples-to-apples population set. So next, the recent ISHLT Hepatitis C virus consensus conference recommendations were discussed. And this is a study by Schlendorf and colleagues from Vanderbilt. And they completed a single center prospective study of 80 adult patients that underwent Hep C positive donor transplants. To date, this has been the largest published experience in heart transplant. The 80 positive patients were compared to 159 Hep C negative donors from the same time period. As you can see, the Hep C diagnosis includes a nucleic acid-based test, or NAT, and if this is positive, which typically happens within 5 to 7 days of infection onset, then this means that the patient is Hep C viremic, versus the other diagnosis where the antibody, if that is positive, which takes about 2 to 6 months to develop, but the NAT is negative, this is considered to be non-viremic. And in the case of this study, the non-viremic hearts, which was the 10 antibody positive NAT negative hearts, did not lead to any virus transmission to the recipient. They noted that the most common Hep C genotype was 1A, and median time from transplant to viremia detection was 5 days. They initiated patients on various direct-acting antiviral agents, and this was per institution, as this was a multi-center study. And the time to initiate this was about 55 days post-transplant, which was when the patients were deemed to be clinically stable. Although various therapies were used, majority of them, or 50% of them, received ledipasvir, sofosbuvir, or Harvoni for 12 weeks. Study outcomes between negative and positive donors were similar in terms of 1-year survival and incidence of rejection at 1 year. Additionally, I want to discuss the follow-up data that was available for this study through May 2019. And as of that point, there were 50 patients that had completed the entire hepatitis C treatment with the DAA, and 37 of those had reached the follow-up period, which was the 12 weeks after completing it. So that allowed the patients to be assessed for SVR or sustained virologic response 12 weeks post-completion. Out of the 37 patients that were assessed, 100% of them were successfully cured as evidenced by SVR12. There are 13 patients that have completed treatment but are in their 12-week follow-up period before assessing SVR. It is notable that there have been 0 treatment failures and only 1 report of premature treatment discontinuation due to patient death. Ultimately, authors concluded that among heart transplant recipients who develop a donor-derived hepatitis C viral infection, 30-day and 1-year patient survival rates exceeded 92% and 90% respectively, and that the direct-acting antiviral agents were well tolerated and yielded SVR12 rates of 100% despite being on immunosuppressants. So here I just want to quickly look at the national utilization rates, where they looked at the rates of accepting a donor heart for transplant by Hep C positive, antibody positive hearts for transplant, and they found that non-viremic versus viremic hearts were actually numerically similar to Hep C naive hearts. The data published by Madden and colleagues shows a statistically significant trend that's increasing for the transplant of Hep C viremic and non-viremic donors compared to previous years in 2017 and 2016. The UNO survival outcomes show that there was no difference in 1-year survival between Hep C positive hearts from 2016 to 2018 versus Hep C negative. And the downstream effects on transplant centers is fairly significant in terms of decreasing the median waitlist time and increasing transplant rates pre and post accepting Hep C hearts. So here I just have the different direct-acting antiviral agents that are available listed for your reference, and the doses as well as the genotypes. So Epclusa, Vosevi, and Mavorite are pangenotypic. As such, they cover every genotype of the Hep C virus. For the 2 different strategies that can be used, preemptive versus prophylaxis, there is new evidence starting to be released about prophylaxis strategy and how you can start it immediately post-transplant and continue those patients on a shorter duration than the others. And then on the right, as pharmacists, our biggest concern is how do we manage these patients? So it is important to monitor various labs as well as drug-drug interactions, especially since patients may be on immunosuppressants that could interact. And then also to look at their comorbid conditions of specifically renal function and liver function. Drugs of choice in cirrhosis are Epclusa and Harvoni. So ultimately, the ISHLT Hep C Consensus Conference recommended that use of Hep C v NAT-positive organs can be used, however, only in the context of experienced multidisciplinary teams with clear protocols and resources. And they also recommended the use of pangenotypic direct-acting antiviral agents. In summary, for the heart transplant updates, immunosuppression management, induction with low doses of RATG may not prevent severe or early ACR. The switch from tacrolimus to cyclosporin may be inferior in terms of 3-year survival and renal function at 1 year. And targeting tacrolimus and sirolimus levels of less than 15 nanograms per milliliter is reasonable to decrease the risk of infection and is better tolerated. However, the risk of rejection should be considered. For CAV, the use of rituximab is not recommended for the purpose of CAV prevention. And for Hep C virus consensus recommendations, the use of Hep CV NAP-positive donor organs with limitations and treatment with pan-genotypic direct-acting antivirals is recommended. With that, I would like to acknowledge Jenna Negrelli for helping me with this slideshow as well as her support in this presentation. And now I'd like to turn it over to Morgan.
Thank you, Shelley, and thank you to the IMTR PRN for having me today. As Tara mentioned earlier, my name is Morgan Mabey-Eiting, and I am the current PGY2 solid organ transplant resident at Massachusetts General Hospital. I'm excited to share a variety of new data presented during the ISHLT 2021 conference related to lung transplantation, as well as some other miscellaneous topics discussed throughout the conference. To get us started, I wanted to first discuss a presentation given by Dr. Lanisha Teague from Washington University related to the use of mycophenolate. As we know, mycophenolate is the most used anti-proliferative agent after lung transplant, but it has highly variable exposure and poorly correlated single time point levels to exposure. And while we know from prior data that there is a genetic component to the variable exposure secondary to the SLOCO1b3, the mechanism has not been fully elucidated. I want to first draw your attention to the first Kaplan-Meier curve on the left of the screen. And given this genetic variation of exposure secondary to SLOCO1b3, we know that overall exposure with a presence of a polymorphism is significantly decreased compared to those without the polymorphism. Additionally, there's decreased time to ACR with the polymorphism compared to none. And there's survival after Clad diagnosed was significantly decreased in patients with the polymorphism. So the goal of this research project was hypothesized for lung transplant recipients maintained on mycophenolate for immunosuppression post-transplant, where the SLOCO1b3 hypofunction polymorphism at the RS7311358 being associated with variability in mycophenolate pharmacokinetics. So they designed this study by taking full pharmacokinetic testing in 44 adult bilateral lung transplant recipients who were maintained on mycophenolate and completed statistical analysis with linear regression to assess the mycophenolate AUC at 12 hours, as well as multivariate linear regression to account for any confounding in the demographic or clinical variables. And at baseline, there were 44 patients that were included in the study, with 12 having identified as having the polymorphism and 32 without the polymorphism. Baseline characteristics were similar between the groups, except for the patients with the polymorphism in the initial study were identified to be on higher average doses of mycophenolate daily, where they were on 2 grams versus 1.5 grams in the non-polymorphism group. So if we look at the results on the right side of the screen, we can see that patients with the GGGA polymorphism had a statistically lower area under the curve of 25.2 versus 35.08, which had a p-value of 0.035 compared to patients without the polymorphism. And it's also interesting to note that patients that had the polymorphism had a significantly lower second peak. When taking this information, the clinical group also further decided to ensure that there was clinical applicability by doing a dose normalized assessment, given the difference in baseline characteristics with the first set of data analysis. And from that, with dose normalization, they still found that there was a significantly different area under the curve at 1 hour, with a reduced area under the curve in the polymorphism group. So the authors concluded that those with the GGGA polymorphism have reduced AUC at 1 hour even with dose normalized analysis. And this is secondary to the SLOCO1b3 hypofunctional SNP at RS7311358, and it's significantly associated with a decreased mycophenolate exposure. And so ultimately, the clinical takeaway from this presentation was that while there are no changes needing to be implemented in clinical practice just yet, it's important to apply this information to follow-up studies as pharmacogenetics becomes more prevalent and financially feasible, where presence of the polymorphism may lead to higher doses of mycophenolate in the future. The second study I wanted to discuss with you today was presented by Dr. Corey DeNuno of Houston Methodist Hospital. And this was based around time to therapeutic tacrolimus levels in our lung transplant recipients. where we know that tacrolimus is standard of care for prevention of rejection in lung transplant patients. And increased tacrolimus exposure can also increase our side effects, but it's important to maintain a certain degree of exposure to prevent any rejection. So the clinical question of this study was if there is an optimal time to therapeutic tacrolimus immediately post-transplant, with the study objective being to evaluate the association between development of immune outcomes, including acute cellular rejection or development of donor DSA, within 6 months post-transplant, as well as the time to therapeutic tacrolimus. For the study design, all patients received basiliximab induction, as well as methylprednisolone 500 milligrams per lung, followed by tacrolimus 0.5 milligrams sublingually or 1 milligram PO twice a day on or before post-op day 2, as well as our standard triple opportunistic infectious prophylaxis with Bactrim, Valsite, and voriconazole. They monitored post-transplant outcomes for ACR with protocol biopsies and monitored donor-specific DSA with Luminex screening at week 2, as well as monthly up to month 6, with a MFI detection threshold of 2,000, as well as any additional for-cause biopsies at the clinician's discretion. And all newly transplanted lung recipients were included if they were transplanted between May of 2016 and December of 2019, with the primary outcome looking at composite of acute cellular rejection and donor DSA development within 6 months post-transplant. Secondary outcomes included incidence of AKI within 14 days, peak FK506 or tacrolimus levels within 14 days, the requirement for renal replacement therapy, and then the time within therapeutic range within 30 days. Ultimately, 222 patients were included in this study, and they ultimately split the two groups and identified them as either becoming therapeutic within 7 days, which was a cohort of 119 patients, or therapeutic beyond 7 days, which was 103 patients. And the baseline characteristics differed between African American race, which was more prevalent in the group that was therapeutic beyond 7 days, weight, additionally, in the group that was more prevalent in the therapeutic beyond 7 days, and double lung transplant patients, which was more common in the group in greater than 7-day therapeutic. The composite outcome of acute cellular rejection and donor DSA was no different between groups, with a p-value of 0.19, but the secondary outcomes did show statistically higher peaks in the less than 7-day therapeutic group with a p-value of 0.001, and no difference in the incidence or severity of AKI, including the need for renal replacement therapy. But there was a higher percentage of time within the therapeutic range for those that became therapeutic within 7 days. So conclusions made by the author is that achieving therapeutic tacrolimus levels within 7 days of lung transplant was not predictive of acute cellular rejection or donor-specific DSA development at 6 months. And despite statistically higher peak tacrolimus levels within 14 days of transplant, patients therapeutic by day 7 experienced similar rates of clinically significant AKI compared to those therapeutic beyond day 7. So the clinical takeaways from this presentation were that in our African American patients, or those that weigh a little bit more, you may need to be dosing more aggressively in those patients. Additionally, we should prioritize hemodynamic compromise over tacrolimus dosing in double lung transplant recipients who need more time for renal recovery. And ultimately, larger prospective trials evaluating the impact of tacrolimus time to therapeutic levels are needed to confirm these findings. The next study I want to talk you through was a presentation given by Dr. Stuart Sweet and involved a multi-center study from hospitals all across the country. And this was regarding the use of rituximab in combination with other induction therapies in our pediatric lung transplant patients. And while we know that pediatric lung transplant patients have poor overall survival, especially even compared to other pediatric transplants or other solid organ transplants in general. And there's really been no improvement in survival between the middle and recent eras. And this lack of improvement in survival has largely been attributed to the progression to BOS or CLAD, where 14% of pediatric patients will progress to BOS or CLAD within the first year after transplant, 50% by 5 years, and 80% by 5 to 10 years. And this is attributable to 25 to 40% of the mortality, where antibodies to DSA and self-antigens are implicated in the development of BOS or CLAD. So this study looked at the addition of B-cell targeted induction strategies to help improve the safety outcomes in pediatric lung transplant patients by reducing B-cell mediated pathology. And this was a randomized, double-blind, controlled study adding rituximab to standard thymoglobulin, tacrolimus, mycophenolate, and prednisone with a targeted enrollment of 50 subjects and an enrollment period of 3 years. Unfortunately, the duration of follow-up had to be reduced from 24 months to 12 months given the inability to reach goal enrollment by the end of the funding period, but this was approved by the IRB. The primary endpoint for this study was to look at composite BOS, obliterative bronchiolitis, retransplant, and death, where there was no formal definition of CLAD at the time of the study creation. Secondary endpoints included the development of DSA, development of antibodies to self-antigens, development of antibody-mediated rejection, as well as safety of rituximab induction, including evaluation of adverse events and infection. By the end of the trial, there were 15 patients that had received rituximab and 12 that had received placebo. And ultimately, they found that the impact on circulating B cells from rituximab led to a statistically significant reduction up to 12 months post-transplant. And the composite endpoint, which you can see on the graph on the right, showed no difference in the composite endpoint of development of BOS, obliterative bronchiolitis, retransplant, or death, with a p-value of 0.514. Additionally, the impact on DSA showed that 2 out of 15 of the patients who received rituximab developed de novo DSA, compared to 8 out of the 12 patients in the placebo group who developed DSA. So there was a higher incidence of development of de novo DSA in the placebo group compared to rituximab. However, there was no difference in development of autoantibodies. So if you look at the graphs on the top, you'll see that the timing of development of DSA in the rituximab group occurred at a slower pace and lower rate compared to placebo, both at the MFI 1000 and 2000 threshold, with statistically significant p-values of 0.004 and 0.002. And on the bottom, we see statistically more DSA in the placebo group with both MFI cutoffs compared to the rituximab group. So the authors' conclusions were, although this was limited by a shortened follow-up time, which may have led to a lack of treatment effect on the composite endpoint leading to type 2 error, there was still a higher incidence of acute and chronic rejection with the use of rituximab induction in kidney and heart transplant. And this difference is related to all subjects related to thymoglobulin in this study, but not in the comparison studies, which mitigates the cellular response of rituximab related to cytokine release syndrome or rituximab depletion B regulatory cells. And so the addition of rituximab to thymoglobulin induction and standard immunosuppression significantly reduced the development of DSA in pediatric lung transplant patients with an increased incidence of infection or other adverse effects. And a larger sample size is required to determine whether this effect will translate to improved outcomes. The next study I want to talk to you about was one that I was particularly excited to hear about at the conference, and this was pertaining to the use of Belatacept in lung transplant patients, and was presented by Dr. Lauren Benninger from the University of Florida. And this is based on the background where we know that Belatacept is used as a strategy for patients to preserve renal dysfunction in patients where a lot of our otherwise immunosuppressants will lead to nephrotoxicity. And while Belatacept has been used as a renal sparing approach in kidney transplant patients, there is a lack of data of Belatacept in lung transplant recipients. So the clinical questions for this study included, will the use of Belatacept improve renal function? Will it impact graft function? And can it change the risk of infections or malignancies? So this was a prospective cohort study in lung transplant recipients greater than 18 years of age who all had to be EBV seropositive, and multi-organ transplant patients were excluded. On the left panel, you'll see the specific criteria for initiation of Belatacept, as well as dosing considerations for this study. Ultimately, 85 patients were included, and data collection underwent from 2018 to 2020, finding a median age of 63 years for the patients, and a median time to initiation of belatacept after transplant was 293 days, with an average duration of belatacept use of 418 days. 66% of the patients were Caucasian. The predominant etiology of lung disease was IPF at 44% and COPD at 24%. The majority of patients were on tacrolimus, MMF, and PRED at the time of belatacept conversion. And ultimately, for our endpoints with renal function, we can see that there was a median of 1 ml increase in GFR after belatacept initiation, which was not statistically significant, with a p-value of 0.68. As well as for graft function, the FEV1 actually increased a median of 85 mLs during the same duration, which was statistically significant with a p-value of 0.0047. Safety outcomes showed that infections, the most common infection seen in the belatacept group was CMV reactivation, which was 27% in our non-belat, which was 27% pre versus 40% in the post-conversion belatacept. And malignancy, there was also a higher incidence after starting belatacept, with the most common prevalence being with squamous cell skin cancer, occurring in 7% of patients before conversion and 10.5% post-belatacept conversion. At the end of the study, 60% of patients were still on belatacept, and 40% had discontinued secondary to either CMV viremia or reactivation, with 8% discontinuing secondary to multiple infections. So ultimately, the authors' conclusions were that this is the largest cohort of lung transplant recipients receiving belatacept for renal-sparing immunosuppression and the longest duration of belatacept use. There was a stabilization of renal function, where most of these patients had CKD stage 3 prior to initiation, and there was no graft function decline. So ultimately, the author's takeaway was that belatacept provides an effective renal-sparing immunosuppressive regimen without a decline in graft function, but there was a tendency toward a higher rate of opportunistic infections and cancers. However, neither achieved statistical significance. I'll briefly also mention the hepatitis C outcomes that Shelley also talked about in the heart section. And this is pertaining to the lung transplant outcomes specifically, and was presented by Dr. Ann Woolley of Brigham and Women's Hospital, where historically we know HCV organs have not been used in cardiothoracic transplant, but with the advent of direct-acting antivirals, there has been an increase in the use of hepatitis C organs and expansion of the donor pool. So this trial involved both heart and lung transplant recipients receiving hepatitis C NAT-positive donors irrespective of genotype to HCV-negative recipients. And in this trial, they received 4 weeks of treatment with sofosbuvir velpatasvir, or Epclusa, which is a pan-genotypic agent that can be crushed, and they received it within hours after transplant. The primary outcome was composite sustained virologic response at 12 weeks after completion of antiviral therapy for Hep C infection and graft survival at 6 months after transplant. And ultimately, 53 patients that received NAT-positive donor lungs were included, as well as 93 recipients who received Hep C negative lungs. Baseline characteristics differed significantly by sex, lung allocation score, as well as restrictive lung disease, and the composite outcome of sustained virologic response and graft survival was no different in the lung compared Hep C NAT-positive lung group compared to the Hep C negative lung group. And clinical rejection was no different, including acute cellular rejection, antibody-mediated rejection, or CLAD. So the author's conclusions were that sustained virologic response at 12 weeks can be achieved after 4 weeks of sofosbuvir velpatasvir initiated within hours of transplant, and leads to sustained undetectable HCV RNA by 2 weeks, and is well tolerated in lung transplant recipients. The next study I wanted to present to you is one that my team was able to bring to ISHLT, and this is related to the use of basiliximab as a mechanism for CNI or mTOR holiday in the setting of a toxicity. where we know that CNI and Mtor inhibitors are frequently used in maintenance immunosuppression, but can also come with a variety of toxicities, including neurotoxicity, hematologic toxicity, and nephrotoxicity. So this was a retrospective single-center clinical review of lung transplant recipients who had received basiliximab therapy during a hospitalization between 2016 and July of 2020 related to adverse effects from either CNI or Mtor immunosuppression, including patients over the age of 18. And ultimately, we were able to include 26 patients, with the most common offending agent being CNIs. Of those, rejection occurred in 38% of patients at 6 months post-basiliximab implementation. 15% of patients developed new BOS, and composite toxicity recovery was 51% at maintenance restart and 62% at 6 months. And all patients with neurotoxicity had full recovery. So ultimately, our clinical takeaway from this study was that basiliximab therapy may facilitate recovery in high-risk lung transplant recipients experiencing CNI or Mtor-related toxicities when balanced with the risk of infection and rejection. But our next steps are to look at a case-match comparator group to be able to assess if the risk of rejection may outweigh the benefit of toxicity recovery. Next, I want to just briefly talk to you about some of the miscellaneous updates that occurred throughout the conference. The first of which being Cytomegalovirus. There was a variety of discussions that were held throughout the conference, and all of them were brilliant. The first included a lovely therapeutic review, which included the recommendation or consideration, rather, of changing MMF to an Mtor, where it may lower the incidence of CMV. Additionally, there were a number of CMV-related debates between Dr. Nicholas Mueller of the University Hospital of Zurich and Dr. Emily Bloomberg of Penn Medicine discussing universal prophylaxis and whether it should be used. And ultimately, the guidelines cite strong evidence supportive of prolonged courses of prophylaxis in our lung transplant recipients, where CMV is associated with decreased survival, impacts the development of rejection, as well as other infections. And you should even consider lifelong prophylaxis in patients that are mismatched. Additionally, there was a debate between Dr. Lori Schneider from Duke and Dr. Camille Cotton from Mass General regarding whether or not immunoassays are ready for prime time. And while it seems that they're gaining steam and there's a lot of things that may help us determine duration of prophylaxis, we are still waiting on some larger clinical trials to fully elucidate the clinical impact of these assays. There were also great discussions related to antifungal use, specifically in dosing in ECMO, where we must consider factors influencing the pharmacokinetic parameters in the patient, including circuit factors from ECMO and patient factors, where our different antifungal agents will have variable protein binding, depending on their lipophilicity and their protein binding characteristics, where therapeutic drug monitoring should be strongly considered with patients where antifungals are being used and they are on ECMO. Additionally, there was discussions about pharmacogenomics, which can lead to altered metabolism of voriconazole. So another thing to keep a lookout for as pharmacogenomics becomes more regular in practice, and to be mindful of potential opportunities for synergism in our patients that have multi-drug resistant infections, where synergism may be helpful in overcoming or reducing rates of resistance in our patients. Another great presentation throughout the conference was one about thinking outside of the pill box with the following therapies, where some of our patients have unique obstacles in drug administration or difficult to treat infections. And so there are a variety of different presentations on the use of inhaled, endobronchial, intracavitary, as well as irrigation of different therapies, both in the setting of salvage therapy or refractory infections, where inhaled liposomal amikacin also showed to reduce cystic fibrosis exacerbations, but still can lead to reversion to culture-positive infections. So it's important to keep that in mind. And of course, it wouldn't have been the 2021 conference without a little bit of COVID discussion. Ultimately, I just wanted to highlight a couple studies that were brought up. So the Solidarity trial showed that while there was a variety of things tried during the COVID pandemic, there's no benefit in in-hospital mortality with any therapies, including remdesivir, hydroxychloroquine, lopinavir, or interferon, and ongoing pharmaceutical additions are still being studied. The recovery trial did show us that the use of dexamethasone resulted in lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone, but not among patients who are not receiving respiratory support. And it's an exciting time to be in the transplant field, where the first COVID-19 double lung transplant recipient did occur back on June 5th of 2020 in Maya Ramirez at the age of 28, done by Northwestern Medicine and Dr. Anit Bharat. And they provided lovely consensus guidelines here. Ultimately, the vaccine data is overwhelmingly showing a lower antibody response, but they're still recommending every solid organ transplant patient should get the vaccine and to not check routine serologies or change maintenance immunosuppression, where this could increase the risk of rejection. And a couple of medications to keep your eye out for include lulizumab and this combination anti-CD40 and anti-CD11B agent, where lulizumab is similar to Belatacept, but is a non-cross-linking anti-CD28 antibody, which will be selective for CD28 blockade and is non-inferior to Belatacept, but will also preserve the Treg functionality and inhibit graft-specific TFH and better inhibit development of DSA, while also inhibiting effector function of memory CD8 T cells. This combination anti-CD40 and anti-CD11B is working on the CD154 and CD40 receptor, where CD154 can ligate to CD11B, so they're finding promising targets with this combination, where it is, antagonism significantly increased the efficacy of anti-CD40 in prolonging allograft survival as compared to anti-CD40 plus control. And then just a couple medications also from the antimicrobial standpoint to keep an eye out for those hard-to-treat pathogens, including new beta-lactamase inhibitors and carbapenems. And finally, some new antifungals, which are really fun to say. One's exciting. It's an oral formulation of amphotericin B. We have ibrexafungerp, which is similar to echinocandins, as well as fosmanogepix, which is a new antifungal class altogether. So a lot of really great things to look forward to help us better care for our patients with these really complex infections. I want to thank the IMTR PRN again for allowing me to join the webinar today, as well as Dr. Jackie Clark, who helped me with this presentation. And at this time, I'll take any questions.
Yeah, thank you to both of our speakers. I think it was a great review, a lot of the content from the meeting. If anyone in the audience has any questions, please put those into the chat. We only have a couple of minutes, but we can try to take a question or two. Okay, so we have one question. I believe this is for our second speaker. And how did you dose Simulect for your study for those patients who had the bridging off of CNI or Mtor inhibitor?
Yeah, hi, Lauren. Great question. So we did standard basiliximab dosing, but we did it about 14 days apart if they required more than one dose to allow time for recovery from their toxicity. So it was just the 30 milligrams, but we would dose it every 2 weeks as needed.
I have a follow-up question about that. How often were patients typically off of either CNI or Mtor inhibitor? And then did they go back to the previous drug, or did many of those end up on another agent?
That's another great question. So a lot of our patients, so the median number of doses they received was 1.5. So not all patients received 2 doses. And so generally our median duration off of either a CNI or Mtor was also about 14 days. And generally, patients were switched to an alternative agent. So if they had previously been on tacrolimus, they were switched to cyclosporin, or alternatively, some patients were changed to an Mtor inhibitor.
Okay, thank you. And then I guess maybe one question for Dr. Goyle, unless we have any more audience questions. You mentioned the higher risk of infection with those patients on the higher combination of tacrolimus and sirolimus in your study. Would you recommend different goals? It looks like with the goal ranges you currently follow at your center, they could kind of fall into either of your ranges based on those goals.
Yeah, so great question. Currently, we are actually looking at a sub-analysis for the different types of infections that occurred between the two groups, and we'll be presenting at the ATC conference in terms of that, so watch out for that. But what we found was that there was a higher rate of bacterial infections in the high group versus the low group. And in terms of these specific target troughs, I would not recommend to change that just yet. I think it's important to get everybody on the same page and make sure that everyone's targeting the lower end to be able to first look at those outcomes and see essentially what happens and if the outcomes are different with a different trough goal versus what we have currently.
Sure. Well, it's 2:00. I don't see any other questions from our audience. So I want to thank everyone for attending the presentation. I want to thank you again to the speakers. I think you did an excellent job, and I hope everyone has a good rest of your day.
Thank you so much.
Thank you.